Okay, good evening, everyone. It is just after 7 p.m. Eastern Time. Thank you for joining us tonight for the Canadian Liver Foundation and the Canadian Association for the Study of the Liver Ask the Expert series and webinar on Wilson disease. My name is Ned Maximovich, and I will be the moderator and host for this webinar. I would like to start by acknowledging that the Canadian Liver Foundation's national office in Markham, Ontario, is situated upon traditional territories of the Anishinaabe peoples and of the Haudenosaunee peoples, covered by the Upper Canada Treaties. We are joined tonight by our presenters, Dr. Jordan Feld from the University Health Network and Dr. Binita Kamath from the Hospital for Sick Children or Sick Kids in Toronto, Ontario. As for our agenda, we will have our two speakers complete their talks prior to moving to a question and answer portion. Please feel free to use the comment feed to ask your questions during presentations, and note that questions will be answered following the speakers' talks. This webinar will be available post-event on the Canadian Liver Foundation website, that's liver.ca, through our online resource hub, liver.ca/resource hub, as well as our Facebook page and YouTube channel in the coming days. For those of you who may not be familiar with the Canadian Liver Foundation, I'd like to provide you all with a brief overview of who we are and what we do. The CLF was established in 1969 and was the first organization in the world created to help people with liver disease. We are committed to promoting liver health and improving the prevention, diagnosis, and treatment of liver disease through our four core pillars: research, education, patient support, and advocacy. Our partners at the Canadian Association for the Study of the Liver, CASL, they're a nonprofit organization that seeks to eliminate liver disease through research, education, and advocacy. Its members include hepatologists, gastroenterologists, pathologists, pediatricians, radiologists, scientists, surgeons, and trainees. At this time, I would like to welcome our first speaker for the evening, Dr. Jordan Feld. Dr. Feld graduated from medical school at the University of Toronto and then completed residency programs in internal medicine and gastroenterology. Following his clinical training, Dr. Feld focused on developing skills in clinical and laboratory research in liver disease, with particular interest in viral hepatitis. He received a Master of Public Health with focus on infectious diseases and has worked extensively abroad, maintaining a strong interest in international health. Currently, Dr. Feld is a clinician scientist based out of the Toronto Western Hospital Liver Clinic and the McLaughlin-Rotman Center for Global Health. Dr. Feld, over to you.
Great. Thanks, Nem. Thanks for the invitation. And it's a great pleasure to be here. As you can see from that picture, some things are, we all age, and I'm going to talk a little bit about that today, but a little bit of an old picture. And as you heard, the thing that I have done a lot of research on is in viral hepatitis, but I actually see clinically a lot of people with Wilson disease. We are fortunate in Toronto to have a very large population of people living with Wilson disease, and I see most of them. So the consequence of that is that over the last number of years, I've gotten pretty familiar with managing this condition, and I'm going to try to share with you some of my experience tonight. So what I'm going to talk about is sort of a medical perspective of Wilson disease in adults, and I'm going to be really trying to put it in the context of my practice at Toronto General now. So I'll first just go over a little bit about how the disease presents, how we evaluate the severity of damage to the liver. I am going to focus more on the liver than the other types of problems that occur with Wilson disease, what types of treatments we have, who needs treatments and which ones, and then what we can do as a group, because I think there is some room for people to get involved in supporting the Wilson disease community. So we all must grow up. Sick Kids is next door to us at the Toronto General. And most people with Wilson disease are diagnosed they usually are diagnosed by people like Dr. Kamath at Toronto at Sick Kids, and then we inherit them when they graduate from Sick Kids and come over to either Toronto Western or Toronto General. Most people are diagnosed in their teens or 20s, but sometimes we do pick up people later in adulthood. I think the oldest person we've diagnosed was in their early 60s, although that is quite uncommon. Unfortunately, now we pick up most people at an early age, either through screening or sometimes if they have a family member who's positive, they are recognized. So people typically will develop problems from Wilson's disease either in childhood or more commonly in their teenage years, sometimes in their early 20s, but as I mentioned, it can go up to as old as the fifth or sixth decade of life. And we see people having liver problems, neurological problems with the brain, as well as psychiatric problems. And sometimes we see a mix of all three of these general manifestations of Wilson's disease. So you really have quite a spectrum, even within the population of people who have liver disease, where we see people who feel perfectly well and have no symptoms at all, and they're identified by having abnormal liver blood tests, or identified through screening of a family member. Then people may have symptoms that lead to getting testing, and they're found to have abnormal liver blood tests and get evaluated and found to have Wilson disease. But unfortunately, we often find people relatively late in their disease progression. Many of the people that we see already have significant liver damage by the time they're diagnosed and may well already have cirrhosis of the liver, which is a damaged and scarred liver. And our most devastating situation is when people present with fulminant liver failure, which is sometimes the first way that people find out that they have liver disease. And that sometimes can only be managed with liver transplantation and can be a very devastating and life-threatening complication of the disease. I'll briefly touch on the neuropsychiatric symptoms. I'm not going to spend a lot of time talking about those tonight. There are a number of them, and they are quite variable. The most common features that people have are things, it's what are called movement disorders, where people will have abnormal movements that they would prefer not to have. So things like tremor, where people will have shaking hands. They may have unwanted movements, sort of like Parkinson's disease or something similar to that you may be familiar with. Very commonly, people will have involvement of their mouth, and this will affect their ability to speak. So they may have abnormal speech, slow speech, speech that sounds a little bit different. They may have difficulty swallowing and sometimes also drooling. And these can be quite troubling symptoms, particularly when they present in teenage years and young adulthood. For people, they can be quite troubling to deal with. The psychiatric manifestations of Wilson's disease really range anything from anxiety, which is extremely common, to very severe psychiatric illness, where people may have conditions that are very similar to things like schizophrenia, with hallucinations and delusions and other very difficult to manage psychiatric symptoms. Now, importantly, most people who have brain involvement, whether neurological or psychiatric or both, already have significant liver disease. And that's because the copper deposits in the liver, and it's only once there's a lot of copper in the liver that we start to see copper getting into the brain. So most of the time, once people already have neurological disease, they very often already have cirrhosis. Not everybody, but the vast majority. So what we're trying to avoid is the challenge of liver disease for all of us in hepatology, is that many people have few or no symptoms until it's very advanced. So I often describe to people that it's a little bit like walking backwards towards the edge of a cliff, that you feel fine until you don't feel fine. And this is really what we're trying to avoid, all of these complications of advanced or end-stage liver disease, some of which can also occur in the setting of acute liver failure, which is sometimes the way that Wilson disease presents, particularly in young people. The good news is that if we treat this condition well, even in people who are diagnosed with advanced liver disease, we see that the liver can improve. So even in people who have cirrhosis, a very scarred liver, they can live long and very productive lives. And we now know, we used to think that it was sort of a one-way street from a normal looking liver on the left over to that scarred looking cirrhotic liver on the right. But we now know that with very effective treatment, we can actually see what's called regression of fibrosis, or some disappearing of the scarring, so that the liver probably doesn't go back to normal, but it can significantly improve. So with good control of disease, we can see that the liver function and even the amount of scarring in the liver gets better over time. Now, we've also improved our ability to assess the liver. So we still sometimes use liver biopsy, often at the time of diagnosis, to make the diagnosis of Wilson disease and assess the amount of liver damage. But we can also assess it more easily with tools such as transient elastography or FibroScan, which is an ultrasound-based tool, which allows us to evaluate the stiffness of the liver without the invasiveness of sticking a needle in. And you can see that when we do this FibroScan test, just by sticking this little probe on the side of the abdomen, we can get a pretty good reading in a few, just in under a minute or so, telling us about the scarring in the liver. And you can see in this graph that going from 0, which is a normal liver, the stiffness of the liver goes up as the scarring progresses over to stage 4, advanced scarring in the liver. Now, if people already have cirrhosis, and unfortunately, as I mentioned, many people do by the time they're diagnosed, then we try to look for many of the complications of this and try to prevent them. So we will screen people for esophageal varices. These are swollen veins that develop in the esophagus, the swallowing tube. And we screen for them because most people don't feel them, but if they get very large, they can rupture and bleed, and that can be life-threatening. So we ideally identify them before they bleed by screening with endoscopy, as you see in that picture, and then either give medication or sometimes a procedure to reduce the risk that they bleed. We also, in people with cirrhosis, screen for liver cancer. The risk of liver cancer increases in people with cirrhosis. It's not particularly high in Wilson disease, but we do ultrasounds of the liver every 6 to 12 months to screen for that. Now, who needs treatment for this condition? Well, I would argue that everyone that's had a diagnosis of Wilson disease needs treatment. So there are people who are carriers for this. They have, in order to have the condition, generally you need to have 2 abnormal genes, 1 from each parent. If you only have 1 abnormal gene, so if you've inherited it from one of your parents, but you have no features of the disease, then no treatment is needed. And so this is important when you think about genetic screening. If someone has Wilson disease, their children will for sure get 1 abnormal gene, but they won't likely have the disease unless the other parent is also at least a carrier for the disease. And if the person is a carrier, then they have an even lower chance, only 50% chance of passing that gene on to their child. Now, importantly, for people who have Wilson disease, diet alone is not enough in almost all circumstances, and different treatments may be more useful for different people at different stages of the disease. But it's important to sort of get your head around the fact that treatment, at least for now, until we have what we hope eventually will be curative therapy, treatment is a lifelong endeavor. And so we generally treat this with 2 different approaches. One is chelation, which basically pulls copper out of the body, and we use 2 main chelators for this, Penicillamine and Triantine, and I'll talk about both of these in a minute. And then we also use zinc, which blocks absorption of copper from the diet. We get copper, small amounts of copper in the food that we eat. And even if you're careful with your diet, there's still a small amount of copper. And in people with Wilson disease, that accumulates in the body. So zinc can help prevent that from happening. So just if you look at this schematic, you can look at this person who has a lot of copper in their liver. You can see these little CU indicating copper in the liver. And when we give a chelator, either Penicillamine or Triantine, it's kind of like putting a magnet and pulling that copper out. And what it does is it pulls it into the kidneys, and then it comes out in the urine. And so you'll probably be aware that we ask you to do the 24-hour urine collections, and this is why, because copper is normally excreted in the bile and comes out in the stool, but in people with Wilson disease, it gets into the urine, and it overflows and comes out into the urine, and the chelators accentuate that and pull more copper out into the urine. Now, zinc, on the other hand, works a little bit differently. So normally copper is absorbed from the gut, from your intestines. And so what happens when we give people zinc is instead of copper getting absorbed through the gut cells and into the bloodstream where it goes to the liver, what the zinc does is it causes something called methionine in the cells inside your gut to increase in the quantity. And what the methionine does is it binds the copper, and it doesn't allow it to get into the bloodstream. So it reduces the absorption of copper. And then when the gut turns over and that comes out in the stool, that copper is excreted, so it doesn't accumulate. And so both of these have their place. I'll talk briefly about the drugs. D-penicillamine, as I mentioned, it pulls the copper out of the tissues and passes into the urine. It's supposed to be taken before, 30 minutes before eating or a couple of hours after eating. And it's important that in addition to D-penicillamine, people prescribed this medication also have to take vitamin B6 or pyridoxine, because the D-penicillamine interferes with its action. And if you get a deficiency of this, then you can have some additional symptoms, which can be quite troublesome. It's very effective. It's been around for a really long time, and if taken well, it can really lead to very good control of the disease. The problem with D-penicillamine is, at least in some people, it has side effects. About 30% of people will have some side effects from D-penicillamine, and this can sometimes mean that you can't take this medication. The most concerning ones are a proportion of people just after starting will have an allergic type reaction with fever, rash, and really feeling unwell. But even people that are taking it for a long time can develop other problems. It can affect the kidneys, it can affect the skin, and it can cause sometimes severe suppression of the blood cells as well. So these are all things that we have to monitor. And the other thing we watch carefully for when people start this medicine is that when it's started as a new medication, it can make neurological symptoms worse, particularly in people who already have neurological Wilson disease. Triantine is very similar to D-penicillamine, but it removes copper a little bit more gently from the body, and that's partially just because it's less well absorbed into the body. So it tends to be a bit milder in how quickly it takes out copper, and it also has fewer side effects than D-penicillamine. The most common things, it's generally pretty well tolerated. Some people have some stomach upset from it, and it occasionally can lead to iron deficiency. It's also taken twice a day, and the good news is that it's now available in Canada. It did not used to be available in Canada, but it is still a little bit of a challenge to get it because it's approved only as a third-line agent. So you have to either fail or be unable to take the penicillamine and zinc to be eligible to get Triantine approved in Canada. Now, zinc, as I mentioned, blocks absorption of copper from the diet, and the important thing is it has to be taken before you eat. So ideally 30 to 60 minutes before a meal, and that way it's present when the copper in the diet comes into the stomach. It's generally well tolerated, but some people do find it to be quite nauseating, particularly on an empty stomach. And so what we recommend is if people take some protein with it, so if you take like a small piece of cheese or meat or something with the zinc and then eat your full meal 30 minutes later, it is much more effective. Importantly, it has to be elemental zinc, but there are lots of different zinc preparations and any of them are fine. The only one that's approved in the United States as a treatment for Wilson disease is something called Galzin or Zinc Acetate. It's not approved officially in Canada, although you can order it online from the US. But any of the zinc preparations that you get from a health food store, the only thing you have to check is that it's got elemental zinc and ideally 50 milligrams, and it's taken 3 times a day prior to meals. Another treatment that is not readily available but has been studied and looks reasonably promising is something called Tetrathymolybdate, which is thought to have a lower risk of making neurological symptoms worse. It's still experimental. There are some trials ongoing, but it's not currently available. Now, sometimes people use combination therapy, and this is done a little more often in pediatric Wilson disease than we do in adult Wilson disease, and that's often because we're inheriting people after they've been treated for a number of years. The challenge with taking both a chelator and zinc is that ideally they should be separated. So this means you're taking treatment 4 to 5 times a day, which can be very challenging for anyone to do. So we typically reserve this for people with more severe disease who present with very advanced liver disease. But ideally, after a period of time, we try to step back to one or the other therapy, depending on where people are at. So if you sort of look at this spectrum of people with different degrees of liver disease, if you take people who are diagnosed either before they have symptoms or just with abnormal liver tests, this is a group who does very well on zinc maintenance therapy. They may start initially with a chelator for a period of time, but these are people who can generally do very well long-term with the zinc. Now, people who have more advanced liver disease, we will always start with a chelator, sometimes in combination with zinc, but usually people with cirrhosis will stay on the chelator long-term. And similarly, if people have liver failure, we will certainly start with chelation with one of the chelator therapies and sometimes additional therapies, but very often the only thing that can be done at this stage when someone presents with liver failure is a liver transplant, which fortunately is curative. Once you have a new liver, the disease is cured, but then you have to deal with the complications of having had a liver transplant. Now, once people are on treatment, it's important that they're followed long term. And so we follow people with a mix of blood tests, and we're measuring the liver tests, we're measuring the ceruloplasmin and the copper. And from that, we can calculate the amount of copper that's the degree of copper in the body. And as I mentioned, we also do the 24-hour urine collection. It's important that this is done properly in correct bottles with a full, proper 24-hour collection. What we're trying to do is get the liver test back to normal. We use the 24-hour urine copper as an assessment of the amount of copper in the body, but it does depend on the treatment you're taking. Because as I mentioned, the chelators, the penicillamine and Triantine, will increase the urine copper. So that's actually what we want to see. High urine copper in someone who's not on treatment is a marker of more severe disease. So you have to know what treatment someone's taking to properly interpret the 24-hour urine copper. Over time, the 24-hour urine copper level should come down as the total amount of copper in the body decreases. And then we will also monitor for toxicity with blood tests and make sure that someone isn't becoming copper deficient just from taking out too much copper, which is rare but can happen. And then we look for other less common complications like bone density problems. Now, I would say our biggest challenge as a adult liver doctor who's taking care of people transitioning to adulthood is really about making sure people take their medication. So these treatments are extremely effective, and people with Wilson's disease live long, healthy lives. My oldest patient in my clinic with Wilson's disease is 92 years old and perfectly well on long-term treatment. But if people don't take their treatments, unfortunately, we've seen things go wrong. So it's not easy being a teen. It can be very challenging for people. No one really likes having a chronic disease, and with the challenges of high school and all the social pressures and add social media and everything else into that, it can be extremely difficult for kids to sort of get their head around this, and as they go into early adulthood, start to take responsibility for this, because this is really an important time, and we have seen some real disasters where people have stopped taking their treatments and developed very progressive, sometimes rapidly progressive disease. So some specific issues that I really focus on with people are taking as they transition into this young adulthood period is really the focus of taking medications and making it their own responsibility. Often parents have done this in childhood. Really helpful to have some systems and strategies to make sure they're on top of this. We talk about alcohol. Many people are going to be tempted to explore alcohol use as they see their friends trying it. And it's really important to avoid this, particularly to prevent progression of liver disease, but also worsening neurological symptoms. And then follow-up is critical. So we try to follow people with Wilson's disease carefully. We really do our best to track people down, but it's really important that we know when people are changing schools and jobs, making sure that if they're going to be leaving the city, that we connect them with a new doctor, because this really is a lifelong condition that needs lifelong management. A couple of special situations that I'll briefly mention. Pregnancy is something that we can certainly manage, and we definitely encourage people with Wilson's disease to have families. But it's important that they let us know when they're planning to do this, and it's important not to stop medications. People developing progressive Wilson's disease, this can be much worse for the baby than the risk of the medications. Zinc is generally the safest medication during pregnancy. So if someone has stable enough disease, we try to use zinc. Triantine seems to be safe, although there's limited information about it. And we generally try to avoid penicillamine because there are reports that it may cause birth defects. And so it's important that people are at least evaluated in a high-risk pregnancy program, although most people have uncomplicated and successful pregnancies. People who are diagnosed before they have symptoms or even abnormal blood tests, this happens often when people are screened because a sibling is positive, is known to have the disease. They generally have mild disease, and these are people who do very well on zinc therapy alone. We'll still usually start with a chelator, but it does depend a little bit on how much copper is on board at the beginning. The diet's important, and some people find this challenging. There are a few things that we really stress that you should avoid, particularly liver. Animal liver is full of copper. Shellfish is particularly high in copper. And then we usually are very strict at the beginning, especially when people are very high in copper, but we understand that this is a lifelong condition. And my feeling is it's okay to cheat once in a while, especially with a little bit of chocolate here and there is not the end of the world. It just shouldn't be a regular condition. But we do try to make sure that people avoid other injury to the liver. So we make sure people are vaccinated for things like hepatitis A and B. I mentioned alcohol, but this is really important to avoid long term. And then we try to stay healthy and avoid things like fatty liver disease, which can complicate this. And a couple of addictions we do encourage are exercise, keeping healthy, which is really important for overall health, but also for liver health. And interestingly, coffee, which is the one thing we encourage people to take, which they seem to reliably take, does seem to slow progression of liver damage and even may reduce the risk of liver cancer. There's a lot of excitement in the field because for the first time in decades, there's actually new therapies on the horizon for Wilson disease. And this is not something that has been possibility or even considered for many years, but there's new medications. So I mentioned Tetrathymolybdate. There's a new formulation of that, which is now called Thiomolybdate. Trials are just being completed for this, and it may be available soon. Hepatocyte transplantation, so just cells, not the liver, are being explored. And very exciting, the prospect of gene therapy. And we may actually have a trial starting later this year to look at this, which would hopefully be curative. And if people are interested in that, you can certainly contact our clinic to find out more. In the meantime, I mentioned that we now finally have access to Triantine, and I thought I would just briefly mention that because it's been a long time coming. For many years, we couldn't get this. There are now 2 brands of Triantine available in Canada, Triantine, which conveniently does not need to be refrigerated, and Waymade Triantine, which does need to be refrigerated. It's still a little bit of a hassle to get access to Triantine. It's got to be approved through the Exceptional Access Program from the government, which gives us approval to prescribe the drug unless you have private insurance. And then even once that's in place, people need Trillium, which is a government-funded program to help support the cost of expensive drugs, which these are. And so this is based on people's financial state, and we can certainly help you with this, and we can generally get the drugs for you. Most pharmacies are not going to carry drugs for Wilson disease, so it's generally better to try to get these at UHN or one of the larger hospitals in the city, so that we can make sure that people don't run out of their treatment. I mentioned before that you can only get Triantine, at least right now, after failing or being unable to take Penicillamine or zinc. Now, I would say one thing we're really missing in Canada is we don't really have a strong advocacy for Wilson disease in this country. There's a great Wilson Disease Association in Canada. They run an annual, in the US, that runs an annual meeting. Many people go to that and they give updates on new treatments and developments in the field. And we are very supportive of this, but I would love to see this coming from our community of people living with Wilson disease and their families to develop a branch of Wilson Disease Association in Canada. There's been some interest in it. It's never quite happened, but we hope that some of you will consider that. So just to summarize, a lot of information, but these slides will be available to you, that Wilson disease presents in different ways, ranging from before symptoms all the way to acute liver failure. But fortunately, treatment is quite effective, especially if we find people before they're preventing with liver failure. It stops progression of the disease and may even reverse it. But importantly, treatment has to be taken lifelong, and adherence with treatment is really critical. Fortunately, if people do take their medications, they can live long, healthy, and productive lives. And this can really basically live a normal, healthy life. It would really be great to have Wilson Disease or Wilson Society Association in Canada, but in the meantime, the CLF does a great job. And so please continue to support their efforts for advocating for all people living with liver disease. With that, I will stop and pass the baton to my good friend and colleague, Binita, who's talked from the pediatric perspective.
Perfect. Thank you, Dr. Feld, for that great overview and great talk about Wilson disease. So as mentioned, we'll pass it to Dr. Kamath. Just a quick introduction here. Dr. Kamath graduated from Cambridge University in England and trained at several London hospitals, including King's College Hospital. And she moved to the Children's Hospital of Philadelphia in 2000 and completed her fellowship in gastroenterology, hepatology, and nutrition. She joined the faculty in 2006 and developed a strong interest in cholestatic liver disease, specifically Alagille syndrome. And she's here with the hospital from Sick Children or Sick Kids in 2009 as a liver specialist, hepatologist, and clinician investigator, continuing to work on a variety of pediatric conditions and biliary diseases, and even utilizing some stem cell biology to develop some disease models. Dr. Kamath, I will pass it over to you and for your talk.
Great. Thank you so much, Nem. It's such a pleasure to be here. And as always, to work with CLF, which is such a great partner organization for physicians and patients alike. So luckily, Dr. Feld gave a really lovely overview of Wilson disease, and I certainly don't want to repeat things, but I also do want to show some of the commonalities between the diagnosis and management between Wilson disease in children and adults, whilst also highlighting some of the differences. So some of the things that you'll hear will be common and the same, and some will be highlighting them differences. So I think the one thing to say about how do Wilson disease present in children, what's our first inclination? So one of the things is that it's predominantly what we'd say a hepatic or a liver presentation. We see far less of the neurologic disease that is seen in adults. So we're really mostly focused on liver signs and symptoms. And also what's frequently seen is that it's picked up almost by accident. So a child is getting blood work, say, prior to a routine ear tube surgery, and we will find elevated liver enzymes, and then we go down the sequence of investigating that, and we diagnose Wilson disease. So sometimes kids present with clinically evident liver disease, but actually quite often it's picked up just by the by for some other reason. And as I've seen there, the neurologic or the neuropsychiatric symptoms are rarely seen in kids under the age of 10 years. But if you do see some of the things that Dr. Feld pointed out, they can be quite subtle in children. And we sometimes talk about declining school performance. An unexpected decline in exam performance or school performance can be a subtle but important sign. So this sort of breaks down the different types of liver presentation of Wilson disease in children. Like I said, it can be truly asymptomatic, meaning there are no signs or symptoms, or it's really subtle. You can get liver failure, which is a much more dramatic presentation and more dangerous, and that's very obvious. The one that I really wanted to highlight in children is that it can really very often look similar to other common conditions that we see in the liver clinic, namely fatty liver disease, and also another condition called autoimmune hepatitis. And when I say mimic them, I can say, particularly with fatty liver disease, children can have mild abnormalities in their blood work. They can have the appearance of fat on the ultrasound. And even the liver biopsy, and I'll go into more detail, the initial view of a liver biopsy can look similar. So we really, at Sick Kids, have tried to do as much as we can to try and educate pediatric colleagues to think about Wilson disease when they see a patient that they think might have one of those other two conditions, which, by the way, are more common. And so what you want to do is make sure that your mind is open to these other conditions, these other possible ways that Wilson disease can look like. As I mentioned, of course, the acute liver failure of Wilson disease is a very dramatic presentation. We looked at some of the published papers that have been put out there for kids who present with liver failure. And really, most of these kids end up needing a liver transplant. And that's, as I said, not the usual presentation in kids. So just last year, there was a new guideline document that was published in the main American liver journal that most of us will follow to look at new practice guidance for Wilson disease. This is a little technical, but what I wanted to point out here, this is just an algorithm for how we diagnose these children, and adults with Wilson disease. But the most important thing that I wanted to highlight for us in kids is that most of the kids that we see is the block down the middle of this algorithm. So it's kids with liver disease without any other features at all. We do the ceruloplasmin, we do the urine test, but most of our kids do end up getting a liver biopsy. And that and then genetic testing. And that really is, perhaps pediatricians are quite cautious, but we really will go through all of this sequence. So it's not uncommon if there's a child that's being worked up that you would expect all of these things to be done in almost every patient to make a diagnosis of Wilson disease. We use the same blood test that's used in adults, the ceruloplasmin, bearing in mind that there are other conditions in which the ceruloplasmin can be modestly low. And we do the same 24-hour urine copper that's done in adults. Of course, it can be tricky to get a child to collect all their urine in a 24-hour period. And we really understand that that's a challenge for many families. You know, when there's multiple children in the home, how do you make sure that one child is the one that's you're collecting the urine from? So I have to say there are times where we just can't get it ideally, but as you know, it's an important part of the diagnostic test and also for monitoring. Again, just to go back to this issue of the role of liver biopsy, it isn't always mandatory, necessary for diagnosis, but we do almost always do it in kids because we're trying to make sure that there isn't another diagnosis. And it can also look at some of the scarring in the liver. And honestly, a liver biopsy can sometimes be scary for parents when we're discussing it. I can say that we do hundreds of them a year at sick kids. We almost never see complications. And although it is an invasive test, we would consider it very important in the diagnostic workup for Wilson disease. I'm just showing this picture. It's a technical picture, but what I want to show is that the panels A and B at the top are both biopsies taken from patients with Wilson disease, and they look exactly like a liver biopsy would look like in a patient with autoimmune hepatitis or fatty liver disease. And what you need to do to make sure that you get the diagnosis right is to do additional testing on the biopsy. And this really leads us to knowing that it's a team approach to making this diagnosis. We have a great pathologist at Sick Kids. We have great pathologists at Toronto General who we can work with and partner with to help get to the right diagnosis. And we really benefit from that team approach. It's not just us as the hepatologist, it's really helpful to have a thoughtful pathologist looking at the biopsy. I guess my point is that not all pathologists are created equal here, and it really is helpful to have a pathologist who thinks deeply about Wilson disease when they're looking at a biopsy that they might not initially think is for Wilson disease, but to keep their minds open for it. A little bit about the genetic testing. Dr. Feld already touched upon this. So I think the issue with the genetic testing is this. When the we look for 2 copies of the gene that have mutations or abnormal variants in. When it is positive, meaning when you find 2 typical changes in the gene for Wilson disease, it's very helpful. One of the issues I think we face in Canada is that we have a wonderfully diverse patient population that comes from all over the world. And so sometimes the variations they have in their genes have not been previously studied before. And so sometimes we will get a genetic report that isn't completely conclusive. It may say there's one variant in the gene that we think is disease causing, and there's one variant that could be disease causing. And that's where Dr. Feld and I have to we have to think about everything in totality. We have to think about the genetic test, we have to think about the biopsy, we have to think about the blood test, put it all together to make the diagnosis. And I think I'd like to highlight this because I think sometimes we think if you read, you know, the New York Times and Time magazine, that you might think that genetic testing is the be all and end all, and we can always come to a diagnosis. And that simply isn't true, especially when you have an ethnically diverse population as we do. So when it's helpful, it's great. If it's not perfectly confirmatory, it doesn't mean that it's not Wilson disease. It needs some nuance to the interpretation. Where it is really helpful is that if you find what we call a definitive a diagnosis based on mutational testing or genetic testing, is that you can use it to screen other family members. So when you've got a clearly positive test, you can use it to test other family members. And that's a really is a helpful tool. The one thing I would also say is that having the genetic diagnosis can help with the diagnosis itself, saying, yes, I'm confident that this patient has Wilson disease, but it doesn't always tell us what that patient's disease is going to look like. So this is a study that they did in Austria, where they looked at many patients, hundreds of which were children, and they realized that even though having a genetic test could confirm that it was Wilson disease, that it didn't really help predict what that liver disease would look like, predict what would happen to that child with liver disease. So again, I just highlight that genetic testing has a role, has value, but there's a lot more to taking care of a patient with Wilson disease than just knowing what the genetics are. So the treatment of kids with Wilson disease is actually really very similar to what Dr. Feld also just described. We use the same drugs. We have the same access issues and challenges. One might think that in Canada, it might be easier to get Triantine for children. It isn't. We have to go through the same sequence of failing treatment with penicillamine in order to access Triantine. And it's the same process of paperwork, which we are very adept at helping with and would want to help people with. Of course, the doses are a little different. It's even harder to get kids to take medications when you're trying to combine zinc and penicillamine or zinc and Triantine, just in terms of fitting it in a school day. Most kids don't want to take medications in the middle of school. They don't want to have to go to the school nurse. And often, sometimes we have to perhaps sacrifice a midday dose of zinc if it just isn't possible to fit it in. You know, what we don't want is parents having to wake up their children at 2 o'clock in the morning in order to get a dose in, of medication in. So we will try and work to make things practical for life. In some patients, we have found that using some vitamin E can be helpful when the liver blood tests don't perfectly normalize. This is a pretty benign thing to do, but you may be aware, and certainly some of my patients will have some vitamin E just as a helpful adjunctive treatment to the main therapies that Dr. Feld also just described. The monitoring is exactly the same. We look for a patient to feel better. We look for the blood work to improve. We look for the 24-hour urine copper to get better, which initially, as was mentioned, will go up and then will fall. And so very, very similar testing and monitoring. Just a word about looking at, I'm trying to look at siblings. This is a very common thing that we do in our practice, that when we diagnose Wilson disease in a child, we will screen all the siblings. As I mentioned, if you have a mutation, a genetic test, you can look for that. But sometimes it's even easier just to look at liver tests in the other children and a ceruloplasmin. If a child is very young, under the age of 3, often you can just use zinc, as Dr. Feld described for other asymptomatic patients. What's interesting is what might be coming down the line is some type of newborn screening, perhaps something that could be brought in areas where there is a high frequency of Wilson disease. And there is some new research coming out on a way that you could do it on a dried blood spot, which is like kids have their newborn screen, that you could actually include testing for Wilson disease on newborn screening. So that's something that's exciting that could be coming in the future. So what are some of the challenges for children? And I think actually Dr. Feld already hit on many of them, but I think that some of them are more acute for kids. It's just hard to take meds when you feel well, right? And particularly for a busy teenager, it's really hard. It's hard to avoid certain foods like chocolate. And I completely agree that it's okay to cheat now and again. But for younger kids, it's really hard to go to lots of birthday parties. And, you know, there can be a birthday party every weekend, and you can't really be having chocolate every weekend. And I think for many of our patients, coming to the hospital, missing school, getting blood work all the time is annoying. And when we work with our patient population, we hear these things, and I think they're really important to us. And what that made me think about is I wanted to share a study that we've been doing. I say it's just a small study, but just to show that for us as physicians, it isn't just about, are you taking your meds? What does your blood work look like? We do actually care about what's going on in your life in general. And we listen to what you're telling us, and that actually helps us do and design research studies that hopefully can lead to future better treatments. So this is a study that we've been doing at Sick Kids in connection with the Children's Hospital of Philadelphia. And basically what we're doing is we're giving patients with Wilson disease, parents and their parents in our clinic, questionnaires to try to understand what is your quality of life, and how is your cognitive or your, as it were, brain functioning, how are you doing? Now, you may tell us, we don't need to tell you that because you know that you're living with it. And certainly parents and families and patients are the experts here. But if we study these things systematically, then we can take it to the wider community. We can educate our colleagues, and perhaps we can think about better therapies or targeted interventions that could help children in school. So what we've done here is that we've compared these questionnaire data between children with Wilson disease and then healthy controls. And we look at the differences and we sort of stratify them into small, medium, and large differences. So when you see a large difference, that means there's a big difference between a patient with Wilson disease and a healthy person in the population. So just a little, I know this is very technical with a lot of numbers here, but I think I just want to highlight for you, this is a standardized quality of life questionnaire score. And when you look at the scores, the total scores, the physical health scores, and the psychosocial health scores, patients with Wilson disease have a big difference from healthy controls. They are not, their quality of life is clearly impaired or worse. And importantly, school function is also worse in patients, children with Wilson disease. When we look at the parents, and this is when the parents think about their child's quality of life, we see a similar picture, that parents also observe that their children with Wilson disease have worse quality of life and worse school functioning. We also looked at some of these cognitive functioning scales, and we can see that kids and parents also see differences, so that they're not doing as well in school functioning. So this is really important to me as a pediatrician, because again, I care about more than just whether you're taking your medications or what your blood work looks like. What this is telling me is that there is a whole important area that we need to address and to target in schools. Perhaps some kids need additional intervention, additional help in school, so that they can meet their academic goals. So in conclusion, just for this, but I think that we've got this nice study going that shows us that quality of life is impaired in children with Wilson disease. We can see that there's impaired cognition and school functioning. And what we'd really like to know is why this is happening, and can we do something about it to target it? So I will leave it there. My take-home points of today, that it's really important to consider Wilson disease in every child that presents with a picture like fatty liver disease and autoimmune hepatitis, which are more common conditions, and we don't want to miss Wilson disease. Most children have a hepatic or a liver presentation, and neurologic involvement, when it's there, may be subtle. The liver biopsy is still very useful for diagnosis. For us, it's particularly important, and so I still include that in my management, in my diagnostic workup. And though there's an important role for getting genetics, it's helpful when we have it, but it's not a perfect test, and it doesn't always predict what will happen in the course of Wilson disease. It's helpful diagnostically, but may not predict what the future will be. And I do think that we have to pay attention to some of these other issues in Wilson disease, not just pediatric and adult Wilson disease, such as quality of life and neurocognition. And I will leave it there. There we go.
Thank you, Dr. Kamath, for that great overview there. Definitely quite a bit of information for our viewers today. This is definitely going to be available, this video, afterwards, so people can kind of focus on what two speakers were kind of talking about. So quite a bit of questions that were going through the feed. The feed was a bit laggy earlier on, so the first 5 to 6 minutes may have been cut. So some of the questions probably are arising from that. I guess one of the questions, perhaps Dr. Feld, you mentioned with Triantine access or some of the other medications, would that be the same across the country and not just Ontario? Or perhaps from your experience, I guess access and in your clinic specifically, have you heard from others in other provinces of what they're trying to do to perhaps speed the process, or is the entire country kind of going through a bit of the access issues?
Yeah, it's a good question. I mean, I don't want to spend too much time on it, but when Triantine was finally, so for many years, Triantine was not approved in Canada, so we had to import it from the US. It was a bit of a nightmare logistically. And I assumed that when it got approved in Canada, that would make access easier. There was a period of time where it made it more difficult, which was really quite frustrating, because although Triantine is not a new drug, it's been around for about 50 years. It's just that there was no manufacturer that had applied to Health Canada to get it approved, basically because there's not very many people with Wilson disease, and they didn't anticipate making significant profit from it. So there was quite a delay in getting it. And then once it was approved, then there was this challenge where every province funds drugs slightly differently. And I did focus on the Ontario situation. I apologize for that, being a little Toronto-centric, sorry. it is in the situation first is that it has to be Health Canada approved, and then every province will have a pathway for helping to fund the drug. So it may be slightly different, although what I described in Ontario is fairly similar, to my knowledge at least, in most of the provinces in Canada. It is available everywhere now.
Perfect, thank you. One of the questions here with respect to zinc as treatment, can it completely control liver function tests? Some specific questions with respect to some family members who had mildly elevated enzymes on zinc for well over 3 decades, and I guess they're wondering, can zinc treatment completely control or can at least balance out some of the liver enzyme tests?
Yeah, so in people with relatively mild liver disease, zinc is quite an effective therapy. Our experience in this sort of mirrors what's also written in the medical literature, is that about a third of people are well controlled on zinc. About a third of people, it's not adequate. They need more intensive therapy with chelators. And about a third of people don't tolerate zinc that well. And so they have issues either with adherence or with side effects. So I usually find only about a third of my patients can take it, but there are certainly good examples of people with long-term successful zinc therapy. That being said, if the liver tests are not normal, I mean, for me, successful zinc therapy means that the liver tests are normal, that the 24-hour urine copper and the blood copper levels are in the right range. And if they're not, that's actually when I start thinking that maybe zinc isn't adequate, and we think about going to a chelator. We don't want to wait until someone has worsening symptoms to step up their therapy.
Perfect, thank you. Dr. Kamath, anything to add on your end with respect to that from your experience?
No, very, very similar. But I know that in some, yeah, I mean, I think we in pediatrics rarely treat with zinc alone unless the child is very young. So we're pretty cautious, and we will usually use chelation in combination with zinc at least for some years before then stopping the chelation.
Perfect, thank you.
And I also mentioned we almost always start with chelation. The only people that we ever treat only with zinc, and this is only in people who are people that are diagnosed through sibling screening, and at first diagnosis have very low levels of copper, either on liver biopsy or from our other testing.
Great, thank you. A few questions here from a few folks who are probably partners or caregivers, or folks who aren't living with Wilson's disease, but their loved ones are. And they're wondering if since they're not considered, they don't have mutations of Wilson's disease, should they still be getting their children tested for the gene?
I think is the question that if they have Wilson disease and their partner's been tested and
Correct.
doesn't have Wilson disease?
Correct.
Yes. So, it would be exceptionally rare in that situation. However, not, to be honest, completely impossible. So, there are, I don't want to go into the details of how that would be possible. I think that in that scenario, if you have a mutation, if one parent has a known mutation, you could get your children screened. That's one thing that you could do, or that you could just have their liver tests checked. It would be unlikely, but it's not impossible.
Yeah. And I think the only thing that I would add, and I think Binita explained it really well, is that you can't totally rely on the genetic testing. If the genetic testing, it's very helpful if it's positive, but if it's negative, particularly in a diverse place like Canada, it doesn't necessarily mean you don't have Wilson disease. We have probably 5 to 10% of people with clinical evidence of Wilson disease will test negative by standard genetic testing.
Exactly true. And I think, if people look at the medical literature, if there are doctors who are reading the medical literature, it's very biased by European data. That's the nature of research sometimes, but particularly in this field, it's dominated by European literature where there are different genetic variations to the ones that we see in our diverse population. So I think that, Jordan and I probably spend more time making sure that we've evaluated the liver in addition to having looked at the genetic tests. So just reiterating the same point.
Yeah.
Perfect, thank you. I know during the talks there's some, some general discussions on some of the other conditions that may present similar to Wilson's disease. I know Dr. Kamath, you mentioned kind of autoimmune hepatitis. few questions relating to whether fatty liver disease or liver steatosis or NAFLD is common in Wilson disease patients who are on maintenance therapy, or any specific biliary conditions, whether it's PBC or PSC. Or let's tackle that one.
Well, I mean, I did talk a little bit about fatty liver disease. I think the point I was trying to make is that fatty liver disease can look like Wilson disease. And when we see a pediatric patient with fatty liver disease, we'd make sure that we do a screening test, at least the ceruloplasmin for Wilson disease. So that's one issue when the two can mimic each other. The separate issue is that fatty liver disease is becoming so common, even in the pediatric population, that you could have Wilson disease and develop fatty liver disease. That's a different issue. One is misdiagnosis between the two. The other is the two of them coexisting. So even in my pediatric population, we see a lot of fatty liver disease. And of course, Jordan, you see way more than me, so you can probably comment on that better.
Yeah, and I mean, that's why I showed that, you know, the things we do watch out for are alcohol and fatty and non-alcoholic fatty liver disease. Particularly as people are aging, that obesity is more of a problem. But and they do look very similar. So on a liver biopsy, if you don't do it properly, as Binita showed you, you can miss the diagnosis. And at least we've occasionally seen that, where someone's been sent to me for evaluation of fatty liver disease that was behaving a little bit atypically, and we ultimately diagnosed them with Wilson disease. But that doesn't happen very often.
Perfect, thank you. We'll probably just take one last question here with respect to disease progression. I know it's a bit broad in terms of what the general life expectancy is, but when would a transplant be in consideration? That's one of the questions that appeared in the chat.
I mean, I think so. Most of the time when a liver transplant is required, it's usually when someone's presenting with a severe acute presentation. And so what this is, we talked about it, both of us touched on it, that some children, some adolescents, it's pretty rare in older, beyond adolescence or early adulthood, that people present with a very severe acute liver failure. And when that happens, really the liver fails, and despite our treatments, people progress and need a transplant. The only other time people need a transplant is if there's problems with adherence. So in people that I follow long-term with Wilson disease, even people with cirrhosis, we have people that have had cirrhosis for decades and are doing just fine as long as they take their treatment. We have occasionally transplanted people where they fell out of medical follow-up, stopped taking their medicines, and then had progressive disease that wasn't easily fixable with treatment, and they needed a transplant. But the expectation once someone is diagnosed is that they should never need a liver transplant, provided it's managed properly, and that they should live a long, healthy, and productive life. As I told you, my oldest patient is in her 90s, and I have a number in their 60s and 70s who are doing just fine.
Yeah, I'll just add to that. I, of course, totally agree with Jordan. I will just say is that, especially in pediatrics, most of the patients we diagnose don't have advanced liver disease. So we can get them onto treatment and they will do well. It's the patients who either present very sick or have advanced scarring when we get them that it can be difficult, that they already have evidence. But all of my patients, really, almost all of my patients, I'm able to successfully transition to Dr. Feld's clinic. And Dr. Feld tells me that they're all doing well as long as they take the medication. And we're very fortunate. I would just say one other thing is a general issue that I think the CLF is very supportive of also, is that if there are pediatric patients who feel that they're not able to find an adult practitioner that can take on their child's care or that has knowledge, like we have such a lovely and seamless relationship with Dr. Feld, that I'm sure the CLF would help direct questions to us so that we can facilitate that, because this is a lifelong disease that needs lifelong attention.
And it is really quite rare. So, I mean, it's important to remember that, you know, it's not fair to criticize your doctor if they don't know too much about Wilson disease. The truth is, you may well be the first person that they've met with Wilson disease. In a clinic like mine, I follow a little over 100 people with Wilson disease by by standards of this condition, that's a very large population. But just to put it in perspective, we follow thousands of people with fatty liver disease and people with other common causes of liver disease like hepatitis B and C. So this just shows you this is quite a rare condition, and it's really, I would recommend that at least someone gets evaluated by a real specialist in this. And then we do a lot of co-management. I follow people, in truth, out of the province where I communicate with their doctors regularly and make sure they're getting appropriate management. But they will send me tests and give me, and I can provide feedback. And that's generally something that certainly not uniquely available in Toronto. There are many experts around the country that can provide that kind of care.
Perfect, thank you for that. Okay, well, with that final answer, that concludes the webinar for this evening. I have to take this time to thank both our experts, Dr. Feld and Dr. Kamath, for the wonderful talk on Wilson disease and providing some hope for those patients who thought it was considered a disease that progresses very quickly, and it's something that we get from the CLF from some of these folks who reach out to us in fear or in shock when they do get a diagnosis, and they worry for themselves, their caregivers, and potential families. So it's always reassuring to provide them with this type of education and support. So I want to thank you both for that, and I want to thank our partners at Castle for helping us with this webinar. As mentioned, this webinar will be available at CLF Resource Hub. It's our new digital online hub. So that's liver.ca/resource-hub on our Facebook page that this is being live streamed on, and our YouTube channel over the next few days. So again, if we haven't had a chance to answer any of your questions, rest assured we will try to answer them all in the comment feed, and of course direct you to some necessary or required resources. So of course, to learn more about Wilson disease and all the liver diseases, or to find out more about the CLF, please visit liver.ca, and be sure to follow us on social media for all the most up-to-date information and liver health tips. I want to thank you all for your time, and take care.
Bye-bye.